most of us. So without wasting time, I think let us start with the first case. So please introduce yourself and tell us whether it's a short or a long case.
Yes, ma'am.
Good morning, everyone. First we present the short case of which is a foot case of a CTEV.
Good morning, respected faculty, and good morning to my fellow colleagues. I am Dr. Ashraf Sheikh from KEM Hospital, a junior resident from the third year, the exam going batch, and I've been given the case of a case of congenital talipes equinovarus, and I will be presenting it as a short case. This is a 3-year-old female child, a case of bilateral idiopathic recurrent congenital talipes equinovarus, with the parents being concerned about the deformity of the child, and informant is the mother. The patient is a second-born child out of a non-consanguineous marriage, born at an institutional center with full-term normal delivery with no prenatal, natal, perinatal or postnatal complications. All developmental milestones till date have been achieved and the patient is immunized till date. I would like to proceed with the treatment history. The deformity was noticed at birth. The deformity of the child of both the feet was noticed at birth. At that time, the mother was counseled was taught to undergo some kind of manipulation at home. So the mother continued with some kind of manipulation at home for a month. After that, she was called to the hospital, and serial casts were given which were around 11 casts at a duration of 7 days. So weekly casts were given, which were 11 in number. Followed by that, there was some kind of a surgical procedure which was done just above the ankle on both her feet. After that, she was kept in a cast for approximately 3 to 4 weeks, and followed by that, the cast was removed and she was given some kind of shoes which were connected by a bar, which she had to wear for around the entire day. They continued wearing the shoes for an entire day for approximately 1.5 months. After that, the child started walking and playing, and they reduced the time to around 9 to 10 hours. The patient continued to wear the special shoes for around 9 to 10 hours for 1 year. Followed by that, there was the COVID-19 lockdown, where the size of the shoes started getting smaller and the patient could not wear it. So since that time, the patient has not been wearing the shoes. The parents have noticed the deformity approximately 3 to 4 months after she stopped wearing the shoes.
So you've given quite a detailed history, but yes, since you know that this is a short case, yes, your main focus,
is on examination.
Everybody
yes,
knows, the examiners know it's a case of CTV.
Yes.
So I think it will be better if you cut short the history part,
okay,
because this will waste a lot of your time and you lose out on the proper actual examination. So everything was good, but try to summarize it and give in very few sentences. Okay. And then come on to. So what we are interested in is whether when she was put in the brace, whether the feet were completely corrected, then you can say that the recurrence is there. So whether it was a residual deformity or a recurrent, that is very important from the history, what you should know. Yes. So of course that the parent's perspective, but that is important. And secondly, the reason for recurrence, which you have justified because of lockdown or non-compliance, means not wearing the brace.
Yes.
So cut down the history. Okay. And also in one thing in plaster, always mention whether it was a proper above elbow, so whether it was done by a competent surgeon person or no.
Yes,
that is also again important, because an improper execution of Ponseti method and an improper treatment may be another cause for recurrence. So we
yes,
should know the salient features from the history, why it has recurred. Okay. From the history, you have to find out about whether it's an idiopathy. Whatever you are saying in your diagnosis, each component has to be justified from your history and examination. So when you are saying idiopathic, if at all anything from the history, you can make out that it is an idiopathy. So you have to rule out other things from history. So any family history,
no,
because you know it is common in family.
No.
So any history of any other deformity or any other issues with the child, any other problem noticed at the back, so whatever from history. So these things will be a proper history. Okay.
Yes,
yeah, continue with the examination. Again, remember it's a short case.
Yes, ma'am.
So very, very specific. Each word, each point has to contribute to the outcome.
Okay, ma'am. Yes, ma'am. So on inspection of the left foot, there appears to be a cavus which is present. At the same time, the left foot is in adduction. there seems to be very slight equinus which is present, and there seems to be a varus of the heel on the left side on inspection. On palpation, I could palpate the talar head slightly. The heel seems to be empty, and I could also feel for a cord-like structure which was probably the tendoachilles tendon. On movement of the left foot, the adductus, which is approximately 10 degrees, could be corrected to an abduction of around 20 degrees. At the same time, the equinus could be brought to neutral rotation. So if I have to palpate for the talar head, I would first feel on the lateral aspect of the leg, I would feel for the fibula. Proceed distally where I can feel the bony prominence of the fibula head. Just below that, anterolaterally, I'll be able to feel a bony prominence, and that would be the talar head.
So just distal and in front of the lateral malleolus.
Yes, ma'am.
Okay.
I'm also trying to palpate for the heel.
So what are you trying to check?
I'm trying to check the bony feel of the calcaneum, ma'am. So I'm able to get a soft feeling, ma'am. A soft heel.
So this you are going to palpate by gently correcting the equinus, or just without correcting?
Correcting a little bit, ma'am.
So partial correction, and
Yes,
then
ma'am.
you feel.
Yes, ma'am.
So you feel it is soft.
Yes, ma'am, it is soft.
Okay, that means it's a severe equinus.
So whatever your findings are, they should correlate.
Yes.
You are saying that there is only slight amount of equinus and you are able to correct it till neutral.
Yes.
And then you are saying that it's a completely empty heel. So something doesn't make sense here. We'll go ahead with the rest of the findings, but we'll. So that is so. What you should do is you should always be clear in your mind that all the findings should correlate.
Yes.
Shouldn't be that one finding you are saying where you are suggesting significant equinus, and the next finding you are saying that there is no equinus to it.
I will try to correct the equinus now up till neutral rotation. So it is possible up till neutral rotation, till neutral flexion on the left hand side. Now I am trying to correct the adductus which is present of the forefoot. एक सेकंड ना बेटा, एक सेकंड. So I'm able to achieve around 10 degrees of abduction.
So a couple of things. So it is always important that the child should be made comfortable. Can you just hold the mic?
Yes.
So the child needs to be made comfortable. The other thing is always try to abduct and then dorsiflex. If you just dorsiflex like this, you are getting a spurious correction of equinus.
Yes.
Right? Sorry, beta. So always try to abduct and then dorsiflex. Are you able to see the foot? Yeah. Sorry. Alright. So always try to abduct. Okay. So abduction is fulcrum on the talar head.
Yes.
So only then will you see the amount of abduction, and then try to dorsiflex the foot.
Yes.
Alright. So you are, as you said, you are having almost a neutral kind of equinus. So there is no dorsiflexion possible, but there is no equinus per se. It's neutral. I still feel that it's not a very soft heel. It is probably a 0.5 for the heel. All right.
Okay.
You can go ahead.
So at the same time, I could appreciate a scar on the posterior aspect of the ankle, and there is some dimpling of the skin on the anterolateral aspect of the ankle. So the Pirani score of the left foot comes up to be around 2.5.
So what is Pirani score? You have not mentioned anything about the creases. Very
Yes,
important thing.
Yes, ma'am. There are no creases which are present. There is no posterior crease or there is no medial crease which is present.
How you got 2.5?
Yes, sir.
Divide into midfoot and hindfoot, and then elaborate how you got 2.5.
The hind foot score consists of an equinus, so I could dorsiflex it till neutral, so that was 0.5. I calculated the empty heel as 0.5 now, so that is 1. And the third thing is the posterior crease.
What do you mean by 0.5 empty heel?
No, means empty heel is 0 actually, but I corrected.
So what is 0, what is 0.5, what is 1?
0 is empty heel, where it is completely soft. It would feel like the lips or the earlobe. 0.5 would feel like the tip of the nose, and one would be feeling of a forehead.
So you said it was a soft heel.
Yes,
So by your definition, it should be 0.
Yes, I corrected.
You are correcting it?
Yes, I just
That's
corrected because.
All right. So it's 0.5, 0.5, 0.5 for the hind foot.
No, so there is no posterior crease, so that would be 0.
0. So 0.5 and 0.5.
Yes, so that is
And-
1.
okay.
And for the midfoot crease, the talar head is slightly palpable, so that would be 0.5. There is no medial crease, so that is 0. And there is a lateral curvature which is present only from the forefoot aspect, so that is 0.5. That is a
Becomes
total
about
of
2.
2. Yes, sir.
2.
So I would like to keep a pencil or a pen on the lateral aspect of the foot. So here I can appreciate that the foot starts curving at the junction of, means when the forefoot begins from the midfoot. So that is why I've given it a 0.5. It would have been 1 if the foot starts the curvature at the midfoot.
Anything different on the right side? You can just go ahead fast.
Yes,
if there is anything
sir.
different.
So the right side is, the deformity on the right side is a little less as compared to the left side. Apart from that, all other findings on the right side are similar to the left side. I could go in detail or.
So can you just summarize the Pirani score on the right side and then we'll go ahead?
Yes, sir.
This is a short case.
Yes. So the Pirani score on the right side is also 2, sir. The Pirani score is the same, but the deformity appears to be more on the left side.
Okay.
As the cavus on the left side seems to be a little greater.
All right.
On sir, on the gait of the patient walks on the lateral aspect of the sole of bilateral feet. Yes, yes. चलो 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 यहाँ पे जाने का चलो 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 चलो. So we can appreciate that the child walks on the lateral aspect of the sole. At the same time, the child also has some component of a dynamic supination recurrent deformity. चलो इधर आ जाओ.
What do you mean by dynamic supination?
Dynamic supination is when when the child is walking during gait, during the swing phase we will see a slight inversion which is seen of the foot, and during the stance phase that disappears.
So how do you define supination?
Supination is a combination of hind foot varus and adduction at the forefoot
And
plantar flexion.
no. So it's inversion, forefoot adduction is the main component, with or without heel varus, right? So that is supination, and which is dynamic. What you are saying is dynamic, that it's only in the swing phase.
Yes.
So whenever we have any clubfoot deformity or recurrence, we always think of two things: whether it's a static deformity or a dynamic deformity or a combination of both. So in this case,
It's a combination of both, sir. Okay. In this case, it's a combination of both.
So the dynamic deformity is the dynamic supination.
Yes, sir.
And the static deformity is the residual adduction.
Yes, the
as
residual
well as
adduction,
heel
the residual
varus.
cavus. Yes, sir. And there is also varus at the heel, sir.
Dynamic supination indicate?
Dynamic supination indicates weakness of the everters, ma'am, which are the peronei, and it also indicates that there is eccentric loading of the tibialis anterior, which is stronger as compared to the everters. That is why the patient has some kind of inversion when the patient is in swing phase, when the feet are in swing phase.
Examination is over, or anything more you want to say?
No, ma'am, there are no other positive findings. Both the feet are of the same length, and I've mentioned the Pirani score. The gait has been mentioned. There are no other positive
So
findings. The
this is,
spine, hip, and the spine, hip, and the knee are all within normal limits. There is no abnormality detected.
That is an important negative feature
Yes.
in case of CTV. You have
Yes,
to
ma'am.
complete the examination,
Yes,
because as we know, many of them are syndromic. You
Syndrome.
have upper limb deformities and all. So that sentence is important. So positive, negative, you have to
Yes,
say.
ma'am.
So
And-
knee, hip, spine, upper limb.
Yes.
Just
Yes.
as one sentence, there are no other deformities
Yes.
which are seen
There
in
are no
any of
other
them. No tuft of hair in the spine or something like
Yes.
that. So just that we know that you are thinking about these things and you have ruled them out.
Okay. Yes. Sir.
Right?
And if it's a unilateral, now this is a bilateral case, but if it's a unilateral, then you have to also mention about the size of the
feet.
foot, the
Yes.
girth of the calf,
Calf.
because you know that there is some shortening of the, there is atrophy of the calf and there is short foot also.
Yes,
So these measurements also have to be included. So you want to summarize your diagnosis, because
Yes,
it's a short case, you have to
Yes,
give
ma'am.
a proper diagnosis.
Yes, ma'am. This is a 9-year-old female child with bilateral recurrent idiopathic congenital talipes equinovirus, with parents being concerned about the deformity.
Here always
With-
mention Pirani score,
Yes,
because
ma'am.
that
Yes.
gives us this in the
Yes.
final
With-
also,
yes.
with
With-
left
with a-
Pirani score, right Pirani score.
Yes, with a Pirani score of 2 in a bilateral feet, with a combination of a dynamic supination and a fixed deformity of bilateral feet.
So how do you want to proceed now?
And the first thing that I would like to do is counsel the parents regarding her treatment, and that the recurrence that has happened is it
You want to
it
do
occurs.
any investigation. See, whenever you
Invest-
come to
okay.
what you want to do further, first thing, think of any investigation.
Yes, ma'am.
Whether yes, no, that, the treatment comes later.
Okay.
You always forget about the investigation. So,
I
do
would
you
like-
want to, so what I want to ask you is, do you want to do any x-rays or
Yes,
you
ma'am.
don't want to
Yes,
do any
ma'am.
x-rays?
I would like to do an X-ray, ma'am.
Why?
Ma'am, in this case, I would like to do an X-ray because it's a recurrence. I would like to see a few angles on the X-ray, which will help me decide the plan further.
CTV cases, do you do x-rays?
No,
or-
ma'am. For a newborn or an
So
idiopathic CT, I
basically,
would
clubfoot
not
is
do
a
any-
clinical diagnosis.
It's a
You do not
clinical
require
diagnosis,
radiological investigation. But in cases where the patient's present little old, or if there is a recurrence, and if you are thinking that there are some structural components of the deformity, you may just want to do the x-rays and check all the angles. Okay.
Yes, ma'am.
So you all should know. I think we'll not go into the detail, but all those
The
which
angles, yes,
angles to
ma'am. The
calculate, what is
talocalcaneal
Stites
angle,
index, all
yes.
that has to be done.
Yes,
Okay.
ma'am.
So now what do you want to? You want to counsel.
Yes, ma'am. First, I
Okay,
would
counsel.
counsel the parents. Then I would like to proceed with the Ponseti method of casting. I would like to proceed and try to correct the deformity by at least around 2 to 3 casts to correct the deformity which it is and reduce it. Then, since she has a dynamic supination component, I would like to wait for some time, and after that we could go for a total tibialis anterior transfer, tendon transfer for the dynamic supination component.
I didn't get you. Why do you want to wait?
Means it is the ideal age is above 3 years for a tibialis anterior tendon transfer. So I would like to wait for till I buy time with the cast, correct the deformity, and then I would like to go for a tibialis anterior tendon transfer.
So she is 3 years, no? You said.
Yes, she is just 3 years. Yes, ma'am. But
So, and why this 3 years? Why not 1, 2?
because of the ossification of the bones of the foot, ma'am. So the surgery would be easier and
Which
possible.
bone are you interested in here? Which bone are you interested in here?
We are interested in the lateral cuneiform.
Okay. Yeah. So I'll not wait in this case. This is a 3-year-old. But what you said is correct. Is that you can give a few casts. So since we are running out of time, we'll just
So
summarize with this.
Apart from that, I would also probably, if the cast does not, I will give her a trial of cast, but if the cast does not correct her cavus, if the cast does not correct her adductors, then I would like to proceed with the posterior medial release as well. So posterior medial release and tibialis anterior tendon transfer for the dynamic supination deformity.
All right, so we'll just summarize this case and then go ahead. So just for everyone, so this was a recurrent idiopathic clubfoot with static and dynamic components, right? So in this case, the static component can be corrected, or at least can be attempted to be corrected with the help of casts, right? In this case, the deformity was a bit supple, so we can attempt good casts. Casts are never wrong. We can definitely attempt Ponseti casting in this case, probably 2 or 3 or 4. If the improvement is happening, why not go ahead? She is going to require a correction for her dynamic supination, which is going to be tibialis anterior transfer. In this case, in CTV, the transfer which is used is the total tibialis anterior transfer from its insertion to the lateral cuneiform, right?
Will you give a brace?
Yes, sir. After I finish the procedure, I would like to brace her.
What brace?
I would like to give her a flexion abduction orthosis till she's around 5 years of age.
Orthosis.
abduction orthosis, which is a Steenbeek brace or a Dennis Brown splint, right?
FAB is
FAB,
foot
yes,
abduction.
foot abduction
Flexion
orthosis.
abduction is your hip thing.
Yes, yes. A Steenbeek's brace or a Dennis Brown brace, which is a foot abduction orthosis.
So in CT, we nowadays, and I think Vadia has a very good paper that, you always start with Ponseti, irrespective of the patient coming at a very young age and idiopathic not treated or any recurrence. Always do serial casting, as Mandar said. Try and correct maximum components so that your surgery will always not be posteromedial release. It's an a la carte approach, whatever is required for that particular patient. So maybe in this patient, you may not require a full posteromedial release. You may just require a posterior release along with a tibialis anterior tendon transfer. So never say a full PMR like it used to be earlier.
Yes.
So try and maximize correction by casting, and then at the end of it, you judge, take X-rays, judge whether it requires lateral column shortening, whether it requires just posterior release, posteromedial release, tendon transfers that way. So that is the new concept, that correction with Ponseti and a la carte approach depending upon what is the residual component of the deformity.
Yes.
Okay. Yeah, I think.
Good.
Yeah.
Well done.
Thank you. Thank you, sir.
So any questions from the delegate about this case before we proceed for the next one? So a small point about what he said, the last point, the bracing. Now ideally, the tibialis anterior transfer is itself an internal brace, right? So it performs the function of a foot abduction orthosis, right? So ideally, after a tibialis anterior transfer, bracing is in the form of a foot abduction brace is not indicated. It is also done at that age where the child is not comfortable with wearing a brace with the bar even at night. So probably you are not wrong if you say that you will give some AFOs during the day just to prevent the deformity from recurring. But it is very unlikely that, it's not scientific to suggest a foot abduction orthosis after doing a tibialis anterior transfer.
Okay.
Right?
Hello. Yeah, we'll begin with the second case.